Welcome, everyone. I'm Dick Deming, Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is surgical oncology, and our guest is Dr. Juan Mira. Dr. Mira is a surgical oncologist at the Iowa Clinic and a friend of mine. So welcome.
Thank you for having me, Juan Mira, surgical oncologist at the Iowa Clinic.
Yeah, and before we talk about the surgical role in cancer, let's just get to know you a little bit. So where are you from originally?
Yeah, so I was born and raised in Colombia in South America till I was 12. And then I moved to the United States with my mother and my brother to Orlando, Florida in 99.
Wow. So 12 years old, moving to, were you already fluent in English when you moved?
We knew some, but we took it, my brother and I took English in school. My mom didn't really know much, but so it pretty much immersion, when we started in 6th grade, didn't really know much English, no.
And so then high school in Orlando?
High school in Orlando. Yeah. I started at 6th grade, 7th, and went to high school in Orlando.
Okay. So one of my favorite questions.
Yes.
How big was the high school that you went to?
750 people.
In your class or the whole high school?
No. The 12th grade class was 750.
750
Yeah, it was a big class. It was over and every year there was some less, unfortunately. But I think it was about 4,000 people for the entire 9th through 12th, and then by the end, I think about 750.
And then what was your claim to fame in high school?
Claim to fame. I was a mediocre golfer. What else I don't know. I think
first of all, I have to say it must be really hard to have a claim to fame in a class of 750.
Yeah, there was. I was valedictorian.
Well, that's okay. That was okay. Yeah, that counts. That counts.
That's a more academic. You would think something more fun than that.
No.
But, yeah.
No. That definitely counts as claim to fame. And then, where did you go for undergrad?
I went to University of Florida, just south and north of Orlando, about an hour and 45 minutes from Orlando, away from home. So
is that Gainesville?
Gainesville, Florida. University of Florida in Gainesville.
Okay. The Gators?
Big Gator.
Right.
As some people know here, I wear my Gator hat when I operate. So.
And when you started college, incoming freshman at the University of Florida, what was your first declared major?
I was microbiology and cell science.
Okay. Did you think you were on a path to becoming a doctor at that point?
Yeah, for some reason, since I was a kid, I always thought about doing something surgical, being a doctor. It was been like neurosurgeon or some kind of, I don't know why, because I don't have any doctors in the family.
Okay.
I liked watching when I was in Colombia. We would watch some shows or do like ER and other things that were medical, and somehow I liked it. But yeah, when I went to undergrad, I wanted to be a doctor, and so it just kind of worked my way up through trying to figure that out as I was starting.
And was microbiology one of your majors when you graduated?
It was microbiology and cell science, and then one of my good friends from high school came to Florida from college and then came to UF for university, and he was a criminology major. And we wanted to take classes together. So I got a minor in anthropology so we could take classes together.
Okay. I thought you were going to say a minor in criminology.
No, we did anthropology because it kind of, I think one of the classes we took together was skeleton keys, where it was, looking out and how to examine bones for crime scenes. But it was criminology and science. So it was kind of work our way through that.
Right. You could have become a medical examiner.
I could have. It could have kept going. Yeah.
So then, through undergrad.
Yeah.
And where did you go to medical school then?
So after that, so when I went to undergrad, I didn't really know much about the system. And we were, been here for, 6, 7, 8, 9, 12th grade, but I didn't really know how it worked. I just applied to Florida. I didn't really know how it was going. When I was in Florida, I finally was like, oh, you need to do research and you need to just try to, pick up your resume so you can get into a med school. So I did some research with a Dr. Kathleen Shiverick, and she kind of coached me through my path. And then from then on, I started interviewing broadly, and I didn't really know where I wanted to go, but wanted to go to a good place. Ended up attending the University of Michigan in Ann Arbor. But it was one of those that I kind of just shot everywhere and see where I kind of got in. You know how that can be in terms of getting into med school.
So University of Michigan, great school. Climate a little different than
From
Florida
Florida,
or
yeah.
Columbia.
First time I saw snow was when I interviewed at the University of Michigan. First time.
And then how was your experience, first of all, just living in a state that had winter?
It was tough. You know, I was away from, it was first time really far away from my mom and my brother. I was 4 years away, only came home a couple of times a year. They visited a couple of times, but it was Michigan is dark. So it was a big change. I loved my experience in Michigan, wouldn't change it one bit, but the winters were tough. And then so I figured next place would be residency. So I wanted to find a place that was a little bit warmer.
So did you have to like learn how to drive in the snow?
Oh yeah, that was my first. So yeah, I got a car. It was a 1997 Mitsubishi Eclipse that I bought for like $1,000, I think it was. Because I, you know, it was like my third. As a third year, you have to have a car because you're driving.
Did you learn about snow tires or chains?
You could not afford them, but yes,
Okay,
I
okay.
did. I did learn about all of that.
Yeah.
So my car actually, just because, you know, it was first year, didn't really come from much. So I bought this car for $1,000 or $2,000. The door handle on my seat wouldn't work, so I would have to kind of open from the other side. In the winter, the car would freeze, so I would have to come through the back, climb through the back into the front seat. So I love that car though, despite all the issues. So I did that, and yeah, it was a front wheel drive, and it was tough to drive for in Michigan, but
amazing life experiences though. And then in medical school, I imagine that it was similar to when I attended, you know, a quarter century before, that the first 2 years were pretty much classroom, and then the second 2 years clinical.
Yeah, still you know, that. So we did, you know, first year, you know, essentially you kind of learn physiology and normal stuff. Second year, you learn the pathology. And then third year you go into the wards, and then fourth year you kind of hone into what you want to do. And
at what point did you decide you wanted to be a surgeon?
So I always kind of wanted to do something surgical, right? And when I mentioned, you know, Kathleen Shiverick and Dr. Rosser, they were my mentors. So she was a PhD in pharmacy, and he was a urologist. And I did cancer research in like prostate cancer and things like that. So I thought for a while that I was going to be like Dr. Rosser, and I'll be a urologist. And then during you do first year, second year. During second and third year, you do some research over summer. And during that time, I got to work in the laboratory of Dr. Bob Bartlett, who had recently passed away, unfortunately. And he was the founder of ECMO, so the extracorporeal membrane oxygenator. So ECMO is a pretty big deal. I worked in his lab. This man did all kinds of research for, you know, one of the longest tenured, you know, grant holders in the country, I would say. And when I worked in his lab, he was a general surgeon. And I got to see, you know, as a general surgeon, you did a little bit of everything. He was a true, you know, old school general surgeon, did trauma. But in his lab, I was able to work with a lot of different folks and individuals. So when I did my tenure in that lab, I was like, you know what, I'm not ready to just do urology or anything else. I kind of want to learn about the entire body and do a general surgery residency.
Yeah. So I think back to that. Oftentimes there's this distinction, unless you know you want to go into something that's very specific, like ophthalmology or dermatology or maybe radiology. There's sort of this dichotomy of medicine, internal medicine and the internal medicine specialties, or surgery and the surgery specialties. So you indicated that at an early point you kind of went the surgery way. Were you always like interested in Legos and erector sets, and were you a builder? And is that?
No, not necessarily, but I did like to break things apart. So when I was a young kid, I had a little hammer, and my mom would remind me about how I would break things apart and see how they would work. So I would more
not so much putting them back
back together. It was more like trying to figure out how they work.
Because you do have to put them back together.
Yeah. So now that's what I do. I pull, but yeah, when I was young, it was always very tactile and messing around with my hands. But yeah, no, not a lot of Legos, not a lot of building, but it just, kind of that was early childhood, just kind of breaking things apart and seeing how things work.
Okay.
It's at least my mom really reminds me of that sometimes.
So now you've graduated from medical school
Mhm.
in Ann Arbor, and you decided to go into general surgery.
Mhm.
And where'd you do your general surgery?
So I interviewed again, buckshot again, and I really, there was a lot of connections between Michigan and University of Florida. There was, people that had trained in both places, that trained in Michigan and went in Florida, or people that trained in Florida and were in Michigan. So I decided to go back to Florida, back to UF.
With the eclipse?
Oh no, I saw the eclipse. So I
saw the
eclipse stayed for the next person. I did. I was able to sell the car.
Okay.
Now that I remember, I bought it for $2,000 and I sold it for $1,000.
Okay.
So it's not bad.
Okay.
But
so
I left it.
Okay.
Went back to Florida. And that car, I still have pictures of it. Just to get nostalgic about it.
I can just picture. Yeah.
I'll have to show you a picture after this. But anyway, so I went back to Florida to UF to do a 7-year general surgery residency.
So a 7-year general surgery residency.
Yeah.
Is that including lab?
So yeah,
or was that on a path to surgical oncology?
No, so it was. So I didn't know I wanted to do surgical oncology at that time. So general surgery residency is either 5 years or 7 years. So a lot of academic programs like University of Florida have a required 2 years of research. So I did 2 years of clinical work, then I did 2 years of research, and then 3 years of additional clinical work.
What was your research?
I did trauma, sepsis, and essentially immunology.
Okay. And as you go through your general surgery residency, you obviously are exposed to the various types of surgery. Urologic surgery, cardiothoracic surgery, surgical oncology. What are the other subdivisions?
Yeah, so
neurosurgery.
Yeah, neurosurgery. We don't do it usually though. So for general surgery, you have neurosurgeons, urologists. We do interact with cardiothoracic surgery, but there are, orthopedics. So we kind of interact as interns. A lot of us interact together. But then from then on, you move in within your specialty. So intern year, you rotate with some orthopedic surgeons, some emergency medicine residents, urology residents. But as your second year, you start to hone into your core specialty. So urologists go be urologists, orthopedic surgeons go be orthopedic surgeons, emergency residents go be emergency residents, and then the general surgeons kind of focus on general surgery. And it's a little bit of everything. So within the specialty, you have everything from esophagus, stomach, small bowel and rectum. So you work with foregut surgeons, colorectal surgeons, gallbladders, tons of gallbladders,
appendix.
Yeah, that's right. And then from then on, you also have the vascular surgeons, cardiothoracic surgeons. So a lot of the specialties come out of general surgery. So it's kind of the plastic surgery can come out of that too, burn surgery, trauma surgery. So it's quite broad. But
in your residency, was robotics already a big thing?
In my residency program at the time, it was not. The program now has developed a pretty strong robotic program, but when I was a chief resident, my 5th year, some of the surgeons were taking up robotics. So we did a lot of laparoscopy, complex laparoscopy, but the robotics part came at my end of training and in fellowship, and I do a huge part of my practice is now robotics.
And maybe for people who might not know what we're talking about, what is robotic surgery?
Yeah, so essentially
R2D2 coming into
kind of DV5 is the name of the most recent one. But so robotic surgery, let's just go back to surgery. So you have open surgery. Let's think about abdominal surgery, which is what I focus on. So you have open abdominal surgery where you make a big incision and do open work. That's the standard for most things.
Get a couple of medical students on either side
retracting.
To hold it
Correct.
open.
We do have the Bookwalter retractor. So it's a metal retractor that holds for you, but the medical students can be of benefit sometimes, helping you add some additional retraction. But yeah, so the open surgery is with a retractor, and you have great visualization. Just did one big case today using the Bookwalter and doing open surgery. That's how we started. Then in the 90s, laparoscopic surgery became more preeminent, and that happened until most recently the robotic surgery. So laparoscopic surgery is minimally invasive surgeries when you hear the keyhole surgery. So essentially you insert a needle into the abdomen, blow up the abdomen with gas, and then create a working space. And then you add additional trocars or ports, so instrument holders where you can put your instrument through and then do surgery. So use a camera, usually a couple of additional arms, sometimes more, depending on what you need. And that's how you do your gallbladders.
So you
most of the
typically
time.
have multiple incisions that are only maybe an inch.
Yeah, about
long.
5 millimeters, so much less than an inch, 5 millimeters to 12 millimeters big, and that's how we do most of our surgery. Sometimes if we are extracting an organ like a gallbladder or a stomach or a colon, we have to make a little bit bigger of an incision to remove that. But that completely changed the field, because minimally invasive surgery, now you don't have this big incision from stem to stern. You have smaller incisions, easier to heal, less pain. Gallbladder surgery is a prime example of the use of minimally invasive surgery. We used to make big incisions below the costal margin. People were admitted for a few days. Now gallbladder surgery is mostly an outpatient operation with small
So
incisions.
much, much, much better for the patient, but really can be challenging for a surgeon who's done all of his training. Well, let's just open it up and you go in there, you see the gallbladder, the liver, everything.
You see everything.
And you take it out and you sew it back up, and the patient worries about healing up.
Yeah.
Now you're doing the surgery basically looking at a screen, and the camera is inside the patient's body, and you're directing.
Right. And you would think that would be harder, and and sometimes it can be, but it's actually easier in some opinion. I think the visualization is excellent. And now when we talk to robotic surgery, so I still do, and I did a lot of laparoscopic surgery, minimally invasive surgery. So you're dealing with straight sticks, right? The benefit of the robot, still minimally invasive surgery, still small ports, still have a camera. Now you're not at the bedside, but the robot kind of comes in, and then the robot doesn't control itself. You control the robot. So you leave the ports in, you go off to the side and start working and doing robotic surgery. When you do that, there is now wristed instruments, so you have articulation, and it completely has changed my practice. So I do, for example, I used to do, stomach surgery, liver surgery, laparoscopic. I've essentially transitioned all of that to robotic surgery. I started doing esophagectomies. I've been here for about 4 years now, almost. So started doing esophagectomies open, belly open, chest open. And then after the first year, then I started doing them robotic in the belly. Completely changed everything. It's just, I think it's safer, it's easier. I'm sitting down.
Right. Okay.
and
so once you learn how to do it, you can extend your career.
It's very ergonomic.
So for people who maybe don't know, here's the analogy I use, but you probably have a better analogy. So I think of going to the carnival as a kid, and you've got the toys in this cylinder with a crane, and you can move the crane, lower it down, and pick up the toy, and then move it over, and it comes out, and then you get the toy. So you didn't go in, you're using a machine to get the organ out. So that's my analogy of robotic surgery, is
that's a great
analogy. Crane at the carnival getting your toy.
I might use that.
Okay,
I kind of like that.
I don't know. Do they still have carnivals with that toy?
I remember those. Okay. Yeah. Okay. So very much so. I think I direct everything.
In a complex one, how many different instruments are in there at the same time? So
the robot has 4 arms. So you have 1, 2, 3, 4. One of those is the camera. So I control 3 arms. Okay. I often have an assistant, so that's an additional hole. So it's usually 5 holes, and one of them, if I'm removing an organ, is going to be a little bit bigger. But again, with the wristed instruments, with the visualization, so laparoscopic is 1 camera. Robotic surgery, the camera has 2 cameras, so you can actually have 3D view, which gives you a lot more ability to gauge kind of what you're doing. And the newer robots, which we don't have yet at the hospital, but we're hopefully getting those. So now you also have tactile feedback, so you can feel how hard you're pulling on tissues. So there's a lot of great advances that are making surgery, in my opinion, safer, easier for the patient, in terms of smaller incisions. And obviously visualization is really important for us when we're trying to remove cancers and tumors. We really want to see what we're doing.
And one of the things, I think, I'm not a surgeon, but that bleeding can be tense everybody up in the room. If you've got bleeding, how are there times where you can't find it and you need to get better visualization, or how would you deal with you've got more blood there in your field of view and you're concerned that there is a bleeder and you need to?
So that never happens.
Never happens.
so
I've been watching too much TV.
Yeah. So yeah, things, sometimes you do get into bleeding. So a lot of it is training. So again, I'm a firm believer that before you start doing a lot of robotic surgery, you need to know how to do things open, because when you can't do things robotic, you need to know how to take care of things open. We're much better, with techniques. I just recently came from a conference where we just share in the community how to do things better, how to visualize better, how to expose better. Exposure just means, moving things around so you can see where you're operating. It's just critical for what we're doing in robotic surgery. So a lot of us share those. Okay, this is how we do safer surgery. That's a lot of videos, lots of conferences, lots of commentary, texting with partners, having partners come to the operating room. So number one is always preparation. Number two, before you get your certificate, you need to know how to take care of bleeding. So when you're doing robotic surgery, if you do get into bleeding, you have to convert to open. Sometimes, not always, but that's something I tell the patients is always a risk. I'm going to always try to do it minimally invasive. If I can't do it, you may end up with an open incision, which is the standard and how we used to do it. So I think a lot of it is about preparation, and you can, most of the time, again, because of the visualization and the wristed instruments, you can control things and find them, and you always have to have a good assistant at the bedside. But when that is not possible, usually it's a little pressure with an instrument, opening the belly and finding the bleeder and stopping it.
Okay. How would you just say, let's get into now cancer surgery. Things have shifted in cancer care tremendously over the past 50 years. And we still sort of have three types of treatment. You have medicine to kill cancer cells, various different types of chemotherapy, immunotherapy, targeted therapy, hormone therapy. We've got radiation to kill cancer cells. And then you have the role of surgery. How would you characterize the role of surgery in the treatment of cancer? It's kind of like the original cancer treatment.
Right. I think obviously surgical care can be, for many patients, definitive cure and treatment. I think because we have better therapies in medicine, medical oncology, or radiation oncology, different techniques, we're seeing that people are living longer with cancer. We're treating people with cancer and finding out that people with stage 3 or stage 4 cancers are now having the opportunity to have surgery. So surgery used to be reserved for people with limited disease. When I talk about stage 1 cancer is limited to the organ, stage 2 limited to the organ, but maybe bigger. Stage 3, now you're going to lymph nodes. This is all very general, but in stage 4 is going to other organs. So, when I started med school and so on, we really weren't offering surgical therapies for patients with cancer beyond stage 3 disease. And now I not routinely, but kind of, I guess you would say, considering at least operations in patients with stage 4 cancer, because our treatments are better and because we're able to, extend the interval of disease longer, meaning from when you were diagnosed to your treatment, and people are living longer with disease. How do we select the right group of patients that may actually benefit from surgery, which we wouldn't have offered them surgery about 10, 15 years ago?
And then there's also the sequencing issue of the treatment. So historically, it was always surgery first, and then you figure out, do we need to do any extra or adjuvant chemotherapy or radiation? And now for many, many types of cancer, it's switched, and we may start off with chemotherapy first, or chemo and radiation, and then bring surgery in at the end.
I think that's a great point. And yeah, I think not only are we offering more, but I think how we're offering is getting more complex because of those reasons you mentioned. I think that the timing of when surgery, I think, a lot of people that come to clinic is not whether I can do the surgery, is whether I should do the surgery. I think one thing about surgical oncology is that you have to step back and we're not technicians, we're not just there to do surgery. We have to think about, is this surgery appropriate within the context of everything else that's going on, and where does surgery fall in the treatment of that patient? Are we doing chemo or radiation first? Are we going to do surgery first, and how are we going to pair all of these treatments that we have available for the patient with surgery?
Yeah, and it's a good point. I mean, it's not that the medical oncologist just decides and sends the patient to you and says, hey, take this pancreas out. Let's talk a little bit about this multidisciplinary approach. And at any institution that does cancer care, this concept of a multidisciplinary cancer conference, what we generically call a tumor board, is an important part of the planning for care. So let's get into specifics. Let's start with pancreas cancer. Sure. Pancreas cancer is not, it's only about the 10th most common cancer, but it's about the 4th in terms of mortality. So it's a type of cancer that we don't have great results with just single modality treatment. There's not many patients that have limited stage pancreas cancer that surgery alone is the cure, and certainly radiation alone or medical oncology chemotherapy alone is not the cure. So it's often a type of patient where we might use multiple types of treatments. So maybe present a kind of a typical sort of organ confined or organ and lymph node type of pancreas cancer, and how that conversation might go in tumor board.
Yeah. So when we present a tumor board to set the scene, it's usually a group of, we do it either in person or online, and it's a group of all physicians that essentially care for cancer patients within that group. So let's say we have a GI tumor board, you have GI doctors, GI surgeons, radiation oncologists, medical oncologists, and we have a number of additional people that are the ancillary staff.
Surgical oncologists, pathologists, diagnostic radiologists, genetics,
people that you may not
clinical trial people.
So yeah, you have your radiologists, as you mentioned. So people that help us reevaluate the images, not just the physicians that are taking care, but the people that are helping us look at the images, identify, evaluate the pathology, and like I said, the ancillary staff, dietitians, physical therapists, geneticists, etc. So it's a big group of folks. When somebody comes in with, let's say, a diagnosis of pancreas cancer, we present their presentation. So this is, Mary Sue. She's 65, and she presented with obstructive jaundice, which is usually the presentation for pancreas cancer. Painless jaundice, meaning they turn yellow without pain, and that's usually due to blockage of the bile duct. We present that she's had imaging, she's had a workup. By the time we get to the tumor board, they've usually had their workup done, meaning they've had imaging to identify the tumor, they've had an endoscopy to better look at the tumor with an endoscopic ultrasound, and they've had usually a needle biopsy. So we review their presentation, we review their imaging, the radiologist goes through the images. Things we want to know about pancreas cancer is where the mass is in the body of the pancreas, in the tail of the pancreas, or in the head of the pancreas, because all of that changes treatment. Then we look at specifically the pathology. Is it a pancreas adenocarcinoma? Is it a neuroendocrine tumor? Is it a cystic lesion of the pancreas? What exactly are we dealing with? And then once we've reviewed the pathology and the imaging, we got to just make a decision about how the sequencing of treatment of the patients. In terms of pancreas cancer, I tell every patient there is no cure with one thing or the other. You have to have surgery, you have to have, chemotherapy, and at times you may have to have radiation. Pancreas cancer comes in starting with, let's say if we talk adenocarcinoma of the pancreas, which when people think about pancreas cancer, that's what we think about, adenocarcinoma of the pancreas, the one that has about 13% all comers, stage 1 through 4, 5-year survival is 13%. So when somebody comes in, we look at adenocarcinoma. Let's focus on the head of the pancreas, because that's what I do in terms of Whipple's, right? So we look at, are they resectable, borderline resectable, or locally advanced, or metastatic? About 50% of people with pancreas cancer present with metastatic disease.
So it's already spread via the bloodstream to other organs. Like the liver.
Correct. And that's why we call stage 4 disease. And so those patients do not benefit from surgery usually. They don't benefit usually from radiation. They benefit more from systemic therapy. So that's 50% of people. Another 25% of people are borderline or locally advanced, meaning that they're having vessel involvement, whether it's the vein or the arteries, that makes surgery more challenging. So borderline resectable, less challenging than locally advanced. And this is where the people are, so may have, lymph node involvement as well. But really the things we focus on is really the vessels or the technical aspect of the operation. So that's about another 25%. And then 25% of those patients are resectable disease, meaning you can, if you desire so, you can go straight to surgery. Most of the time now, the way we treat pancreas cancer, now we're narrowing it down to resectable pancreas adenocarcinoma of the head of the pancreas of those 25% of folks. Most of the time, we're electing to do neoadjuvant chemotherapy with either FOLFIRINOX or Gemabraxane for 6 months of therapy and then proceeding with surgery.
We use the phrase neoadjuvant to mean the chemotherapy is before the surgery, because historically it was surgery followed by adjuvant chemo after the surgery.
Right.
So it's rare now that you would go surgery first.
Yeah, very unusual to go surgery first, specifically. So why do we do this? So this is my explanation to folks. So back when Dr. Alan Whipple was doing Whipples, we just had surgery for pancreas cancer.
And what does the phrase Whipple mean?
Whipple. So a Whipple procedure is a pancreatic duodenectomy. So where you remove, in my experience, a classic Whipple procedure, you remove part of the stomach, the first portion of the small bowel, which is called the duodenum, the head of the pancreas, and the gallbladder and part of the bile duct. You remove all of that, and then you bring a piece of small bowel and connect the pancreas, the bile duct, and the stomach. And so essentially you redo your digestive
So you have to reroute everything.
Correct.
You take out everything you need to, and some of that then needs to have replumbing.
Replumbing, right? So I'm just, fancy plumber, right? So we're just putting things back together. That operation, it's been on for a while, but initially, we just did the Whipple procedure. People didn't do very well with that alone. Cancer recurred fairly quickly, so we started doing Whipple, and we found chemotherapy. So now Whipple followed by adjuvant or after the fact chemotherapy. And then over time, we decided, well, the Whipple procedure is a very big operation. It can take anywhere from 4 to 8 hours, longer, depending on the complexity. And the recovery, you're in the hospital for anywhere from 7 to 10 days, sometimes longer, but about 30% of people are going to have some complication, whether it's bleeding, infection, leakage from the connections you make, especially the pancreas connection. We call that a pancreas fistula. The stomach may not work as well. It doesn't empty. We call it delayed gastric emptying. And so those things can happen to a large number of people. So I would say most of my patients, maybe 60 to 70% of them go home within 7 to 10 days, but some other ones end up spending longer in the hospital. And you're thinking, okay, now you went through this big operation, and now you have to do 6 months of chemotherapy.
You need chemo,
right?
And the sooner you get started, the better. But you can't start
if you're healing, right? And so you're thinking, okay, so 60, 70% of those people are going to do well. What about those other 30 to 40% of people that may not get to chemo within 6 to 8 weeks? So what we do is we started shifting to neoadjuvant chemotherapy. So doing 3 to 4 months up front. And then the 3 to 2 months at the end, and doing a little chemo sandwich. And we're trying to, when possible, just get all the chemo up front, make sure you're doing well. That helps us for a couple of reasons, in my opinion. Number one, pancreas cancer, we think of it as systemic disease, even when it is very aggressive, right? So even when the cancer presents, we are worried that the pancreas cancer has spread elsewhere. So it's not
unbeknownst to us, there's cells that just don't show up on our scans.
And what I tell people is, it's not the cancer that I can see that I worry about, it's the cancer that I can't see that I worry about. So we start with chemotherapy to treat that. And so number one, treat the cancer we can't see. Not just what we can see. Number two, it gives you an idea of the fitness of the patient, right? If the patient cannot do well with chemotherapy, they may not do well with the surgery, right? I may not be helping. And if the tumor blows through the chemotherapy and is chemo resistant for one or another type of chemo, then there is no surgery that would ever help that patient. So I think it helps us treat the tumors we can't see, make sure people get all the therapy, make sure the patient is appropriate for surgery. And also it allows us to, make sure we don't hurt people with a surgery that they may otherwise never have benefited from.
And in some cases, it actually shrinks the tumor and maybe helps facilitate the surgery.
Yeah, correct. And so good point. Yes. And also in pancreas cancer, it doesn't usually make it that much easier all the time, but yes. And it also can help surgery be less radical, right? We do that a lot of times in breast cancers and try to decrease the amount of tumor, decrease the extent of surgery, and decrease the amount of lymph node surgery you may do for other cancers, not specifically for this, but yes, that's also another benefit of doing neoadjuvant therapy. Your surgery may be somewhat less radical in some scenarios, but not so much pancreas cancer, but yes.
So as you mentioned at the outset, I mean, you're an oncologist. You're not just a surgeon, and you're not a technician where some medical oncologist just says, here's my patient, please take out their pancreas. You are involved in the planning, but you're also involved in the care. And with pancreas cancer, as you pointed out, in the run-of-the-mill adenocarcinoma, the cure rate is only about 13%. So you get very connected with patients. Yeah. And was that something you were prepared for? I mean, a lot of times and I'm not a surgeon, but I think of somebody who goes in and gets their gallbladder out, they might not see their surgeon very often. If it's an acute attack, you might see them as you're going into the surgery, and you see them maybe for 1 week follow-up, or the appendix. You don't really establish much of a relationship, but this really becomes a relationship with the pancreas patients.
Yeah, I think, so it's just talking about pancreas cancer, I get to meet them at the time of diagnosis. I get to help come up with their plan for treatment. I get to put their report in and do their diagnostic laparoscopy, where we look before treatment to make sure nothing has spread that the imaging missed. I get to see them after treatment and to talk about surgery. And then I see them every day in the hospital after surgery. And then I personally like to follow a lot of my patients that have, pancreas cancers, melanomas, et cetera. So, do routine visits along with medical oncology. Specifically, it's a big operation. As I mentioned, you're rearranging the digestive system, make sure they're eating well, make sure they're, sticking to the medications that we may have started. So it's, I find that very rewarding, because you're a big part of this, a huge part of any person that's going through this life and their families, and I think getting to see them a few years after we, especially with pancreas cancer, for example, that's huge. So when I went into surgery, I didn't want to just be the surgeon that never saw. I actually appreciated relationships with people, and I saw that in surgical oncology. Not only did I get to be a true general surgeon, since I get to operate in a little bit of everywhere, I also get to have long relationships with my patients, and I get to see how they're doing, and I get to visit, and we get to go through the good times, the bad times, and through the span of their time with as they're healing from their disease, etc.
Let's switch to another type of cancer. Let's talk about cancer that happens in the liver. And so there's at least two different ways of looking at it. One would be a primary liver cancer, which is not historically in the United States has not been very common, but is becoming more common because of hepatitis as being one of the etiologies for developing liver cancer. But a more common situation is cancer that has metastasized to the liver, and probably the most common would be maybe colon cancer that is metastasized to the liver. So let's start with that. That's a stage 4, but sometimes we can actually cure a stage 4 colon cancer that is spread to the liver, and that's often where you get involved with that type of stage 4 cancer, where you may actually do surgery to remove the metastasis.
Yeah, so for liver cancer, as you mentioned, you have primary liver cancers originating from the liver, but more commonly you have metastatic disease from a tumor going from somewhere else to the liver. Classically, colorectal cancer, a lot of patients, over 50%, may develop, depending on their stage, at presentation, a metastatic disease to the liver. So we have multiple options for treatment. Obviously, chemotherapy treats the whole body. Surgery treats the area of disease. So many of these patients, it depends on, it gets complicated. You got to start thinking, okay, is the patient presenting with synchronous colon cancer? So meaning they present with a colon cancer and liver metastasis at the same time. Or is the patient had colon cancer months or years before, and now they're having, liver cancer or a metastatic disease to the liver? So those are a little bit different populations. Frankly, you kind of want to be the latter, presenting later on,
Right.
giving a bigger
We've
interval
already
of disease.
thought you were cured of colon cancer, and then 2 years later you have metastasis. So
Correct.
you no longer have the colon cancer primary.
Right.
That's been taken care of. You just have a liver metastasis.
Right. And so let's focus on that group. It can be a little simpler. So that patient has metastatic disease. If they've never had chemo, they would qualify for chemo because now you have to treat the body. If they've had chemo, sometimes surgery is good enough. And what do we do for surgery? So liver there's different ways we can treat the cancer. So surgically, you can either remove the tumor itself. So in the edge, wedges for the edges. So we can do a little wedge over the edge. If it's more central, you may have to do a formal resection. So you may have to remove, a quarter of the liver or, half the liver to remove central areas within the liver. Another one I also do a lot is ablation. So tumors that are less than 3 centimeters in size, we know that ablation, meaning sticking a microwave needle and cooking the tumor from the inside out, is just as effective. So for a lot of these patients,
let's go back to the wedge for the edge. So I have never operated on a human liver, but I've cut into, a beef liver. It seems pretty bloody. How do you just take out a piece of liver and stop the bleeding of the rest of the oozing that might happen from the liver you don't remove?
Never bleeds.
It
Again,
never bleeds.
Nothing ever bleeds
in your hand.
So, no. So it's all about techniques, right? So for liver surgery, liver is a big bag of blood. All the blood from your gut goes through your liver, gets metabolized, and goes over to back to your heart and for circulation. So when you're cutting through the liver parenchyma, which is the meat of the liver, you have to take account a couple of things. So blood inflow and blood outflow, and then you also the liver makes bile, and then you got to also think about the bile outflow. Okay, so I use intraoperative ultrasound, so I find the area with ultrasound. Then using ultrasound, I find the inflow to the segment, so the blood going in, and then I found the outflow.
So the artery bringing the blood to the tumor,
right,
and the vein taking blood from
the tumor or the liver itself. So the liver has a vein and an artery. So the portal vein and the artery, right, as you know, and then the hepatic vein. But yes, to make it simpler, and there's also the bile ducts run along the artery and the vein. So artery and vein go, and bile ducts go towards the segment, and then you have the vein draining. So I have to identify all of that with ultrasound, and then I essentially carefully with cautery and other instruments are able to kind of clamp along healthy tissue. So whenever you remove a cancer of the liver, after looking at inflow and outflow with ultrasound, you're also trying to get a margin of healthy tissue. You never want to be right on the tumor. So we plan everything with ultrasound, making sure we have a nice margin of tissue around as we're going to the pedicles, is what we call them, the inflow, the artery, vein, and bile duct. We, identify those, clamp those, tie them, or clip them. And then as we're going towards the vein, then we identify that, clamp it, or tie it, or staple it, and then make sure we remove the entire area. So it's all about planning and identifying those big pedicles that are the ones that really cause the bleeding, not so much just the meat of the liver.
Yeah. Well, thanks for explaining that. And you mentioned that for smaller tumors, you can kill the cancer cells by ablative techniques, and that could include heating, or it could include freezing. And now there's some technologies of using ultrasound-directed energy to kill the cancer cells.
Histotripsy is a buzzword now, which is using essentially ultrasound energy to ablate the tumor. It's all very experimental at this time, and there is some academic centers that are using it. It has seen, that we can treat a lot of tumors with the technology without incisions and doing it with ultrasound. The problem that we're seeing right now, and we just need more data, is that the rates of recurrence may be higher than we anticipate. So I don't know where the technology is. A lot of it is, we don't employ it here, and I think most of it right now is meant to be in trial.
Right.
but I think that's coming in the future, not just for liver, but possibly other organs. Very interesting technology.
But when you're in removing part of the liver, let's say a liver metastasis, do you do that robotically?
I do. Yeah, I do it.
Okay.
All of it.
Yeah.
But I try to do most of my surgery robotic.
And if you're doing an ablation, so for people who don't know, I mean, an interventional radiologist can do some ablations, but they just sort of stick it through the skin. They don't make an incision, and they do. But when you're doing an ablation, you've actually have at least a minimally invasive, and you're doing the probe internally. Is that correct?
Right. So yeah. So the way I do it minimally invasive. So it's usually a combination of treatments. So if I'm ablating somebody, it's because the radiologist, there's too many lesions, or we need to do something else. So I think the radiologists do a great job at the ablation and doing technique. Usually when they come to me, it's because it's in an area that radiologists may not be able to find. Another benefit too is I get, they, like, as you mentioned, they do it by CT scan and look at the area. The benefit to me is that I get to make space in the belly and look. And sometimes there's radiographically occult disease that we can see with x-rays or ultrasounds, but you have to see with your eyes. So yeah, so I do it robotically. I mobilize, or meaning move the liver so I can work with it. And then I put a probe on the liver, again, everything from the outside. And then using the probe and the ultrasound, I'm able to ultrasound right on the liver, put the probe through the skin, through the space that I've created, into the liver with the ultrasound probe, and ablate the lesion that way. And then we can monitor it as we go. And then again, we also get to ultrasound the entire liver to make sure we're not missing things.
Right. And when you're ultrasounding the entire liver, the ultrasound probe is on the outside of the skin, or it's on the top, on the surface of the liver. So this is a probe inside the body.
So it's a very fancy, little finger probe about this long that we put through.
So we have 14 minutes, and we're still going to talk about the esophagus, the stomach, and melanoma.
Perfect.
No, we're going to shift. You're going to have to come back for part 2 to talk about some of the other cancers that you. But we want to open up for questions. So we have a live studio audience who will verify. So live studio audience gets the first question. But if you're watching us live streaming, you can ask Dr. Mira a question. Please put your question in the comment section of the software you're using. But we'll start. And Pearl, you get the first question.
Hello, doctor. So I had a question about, you mentioned about histotrypsy, and could that be used in cases like ovarian cancer, for the cancer treatment of early stage ovarian cancer?
So most of the data right now in histotrypsy is with the liver. And everything is essentially still on trial, that we're still people are using more outside of trials, but I'm not aware of anything for ovarian cancer, but I would limit histotrypsy use right now for academic centers that are usually using this on trials.
Okay, thank you.
Next question for Dr. Mira.
I just had a question about the conversation about liver cancer is fascinating, but liver transplants. When you're getting into the liver, do you ever look at a patient and say, well, this is a better candidate for a transplant than liver oncology surgery? And then how does that go today? We heard a lot about it decades ago, but how about today?
Yeah, that's a great point, because we are exploring more of that. So liver transplant for patients with unresectable cancers of the liver. So there is primary cancers like cholangiocarcinoma, and then colorectal cancer, liver metastasis. These are things that are being explored in transplant centers. So usually patients that are young and healthy and have a free interval of disease without disease anywhere else, right? Because you don't want to put a liver transplant in somebody that has cancer elsewhere, right? If they have lung cancer, bone cancer, or metastasis to other organs. So it is something that is being explored. It's very select group of patients that have limited disease to the liver only, that is not able to be treated elsewhere. Because you got to think about it too. Once you have a liver transplant, then you're on lifelong immunosuppressive therapy. And that immunosuppressive therapy may also put you at risk of developing other cancers, or having, cancer cells from that initial cancer that may be dormant elsewhere being controlled by the immune system, and now they ramp up. So it's a great question. There is a lot of centers that are transplant academic centers exploring it. And I think there is a very select group of patients that may benefit from that.
But traditionally, having cancer was sort of a contraindication to transplant.
Yeah.
So most liver transplants are for other diseases, not cancer, where the liver has failed.
Mm-hmm.
But as you have mentioned, they're now with better control of cancer elsewhere, that if there's an amount of cancer in the liver that can't be resected, considering a liver transplant for a cancer patient is now something that's considered, but still pretty darn rare, right?
Very rare, and again, very selected group of patients.
Okay, good. Next question. Yes,
Hi,
Ron.
Doctor. Well, I just want to say we are so glad that you are in this area practicing.
Thank you.
Kind of a general question. You briefly touched on this. So someone that maybe has had hepatitis, are they more of a candidate for cancer later in life?
Yeah. So people with I try to explain this to most people. So most of the tumors we get are as a result of inflammation. When we talked about esophagus, we can talk a little about esophagus. So esophageal cancer, a lot of people get esophageal cancer from reflux. Reflux causes inflammation of the esophagus. That inflammation that turns into metaplasia, dysplasia, which are just changes in your cells that lead to cancer. So to make that analogy, because I think that makes sense, right? For the liver, when you have hepatitis, that's inflammation of the liver. And that can be due to hepatitis from alcoholism, hepatitis from fatty liver, hepatitis from hepatitis C, or viral infections, which is probably what most people think about when you have hepatitis, is hepatitis C or hepatitis B. So that's chronic inflammation of the liver. That inflammation then turns into fibrosis or scar. The scar turns into cirrhosis. So patients that have chronic inflammation of the liver for whatever hepatitis reason, whether it's fatty liver, we call that steatohepatitis, or viral hepatitis, hepatitis B and C, or alcoholic hepatitis, inflammation of the liver because of alcohol abuse, those patients have a higher risk of developing a tumor of the liver. And the transition goes from hepatitis to fibrosis, then to cirrhosis. And cirrhotic patients are usually monitored every 6 months or so to make sure they don't develop cancers of the liver.
Yeah, that makes sense. So and kind of expanding on that, any type of inflammation can develop into a cancer.
A lot, just usually that's the base of the way I think through things is inflammation can lead to damage to your DNA, which can lead to a cancer. So melanoma, lots of sun exposure, inflammation, sunburns, get melanoma. Lung cancer, smoking, inflammation of the lungs, lung cancer. So some are just genetic. People may be predisposed to cancer because of a genetic mutation, and some can be a little bit of both.
And I think the other point is the infectious disease, because we know that there are some infectious diseases that lead to cancer, and hepatitis is one of them. And having vaccination for especially hepatitis B can be a cancer prevention strategy. We think of the HPV, which is the human papilloma virus. The two most common cancers caused by HPV are cervix cancer in women and oral pharynx cancer, or throat cancer in men. There's 4 other types of cancer, but those are the most common. And getting the vaccination for HPV can actually prevent those cancers. So there's a little bit of a similarity with the liver in terms of vaccination. Other questions for Dr. Mira? Yes, Kevin?
Yes, I was just thinking that the last message you want to hear from your doctor is there's nothing I can do for you. You find that sometimes patients want to argue with you about it, or will go to another doctor, try to find a different diagnosis. What do you do?
Yeah, I was actually having this discussion, like literally before I came in here, with one of my radiation oncologists. I think that is the hardest thing. You don't want to take away hope from people. And I think the problem is this: as a physician, I gotta try to make this difficult situation make sense. And sometimes people, I can't help them, and I can't do surgery, or they're not strong enough for chemotherapy, or they're not strong enough for additional therapies. I think when people come in, you want to give hope, but at the same time, you have to be realistic about what is your goals of care, what is what kind of quality of life do you want to have, and how can I help you achieve those goals? So sometimes it is hard, and some people do look for another opinion. But my job as a physician is trying to just take a step back. And I was like, sure, I know you want a cure, I know you want a treatment, but what actually matters to you within the context of everything that's going on? So I think it's yes, I've had patients go out get other opinions because they want the hope of something to be done. And a lot of times, if I can't provide it and somebody else can, I'll send them to that person. But when I know there is no other option, I really have to bring it back to, what do you want this end of life to look like, and how can we make that a reality for you? Because a lot of times surgery, as I explained earlier, some of the surgeries are very traumatic for patients and their families, especially if there's complications, which some of these big surgeries do have. So yes, I think that is something that we encounter all the time. And we have to just kind of walk through it and really take a step back and see how can we help you through this, understanding that there is no other options.
And your style of getting to know patients helps in that communication process. So you can imagine if the communication process is, you see the patient for the first time, you say, sorry, I can't do anything. And that's not going to be very satisfying for the patient and the family. But if you take the time, as you do, talking and explaining and understanding that a surgery that doesn't accomplish ends up being counterproductive and can actually cause more harm than benefit.
Yeah, and I think that's what I get the most out of those interactions. To be able to take care of a patient in these situations, whereas cancer or end of life, you really have to know the patient to be able to counsel them, because it's not a cookie cutter thing, right? And so without those conversations, you don't really know how to treat your patients, right?
We have time for one more question.
Hey, doctor, thank you for your insight. It's really helpful. My question is, I've heard people who had cancer and who are in remission, they take some medicines called ivermectin or fenbendazole. And I've read a lot of people claiming that it prevented any recurrence or it even cured their cancer. So how much of data or research is there on this claim?
So I'll be honest with you. I don't know all the data off the top of my head. I think for me as a surgeon, a lot of these medications don't necessarily affect the perioperative part of the surgery. If anybody is on chemotherapy or if anybody is on additional therapies, I very much ask patients. I see a lot of people that come in with ivermectin or fenbendazole, and it ends up being a personal preference. And there is some data, people have researched it. I just don't know it as well. And usually I'll let them have that discussion with the medical oncologist to make sure that those things are not interfering with additional treatments they may be on.
Yeah, I would say there's ongoing research. So you can go to clinicaltrials.gov, which is a website that it would show you all of the clinical trials that are ongoing with those two medications, along with many other medications, where there has been some promise has been in the animal models, but the actual treatment of humans with cancer with those medications hasn't shown a benefit yet, but those are being looked at. I remember 25 years ago, we were doing studies of colon cancer, and we had a clinical trial with a different anti-helminthic that was used as part of a regimen with 5-FU-based chemotherapy. So those are being looked at, but there's not been any trials that have shown improvement in results, but trials are still ongoing, so you can check that out. Yep. Well, we could go on, but we have run out of time. So this has been wonderful. Our guest tonight has been Dr. Juan Mira, surgical oncologist. One question I didn't ask, how many years of training? So by the time you get through grade school, high school, college, medical school, 7-year general surgery residency, and 2 or 3 year surgical oncology.
Right. So
you must be 62.
Yeah, almost. So 4 of med school, 7 of residency. So that's 11, plus 2 of fellowship.
Okay.
So 13 plus 12.
Okay.
That's a lot.
Yeah, that's a lot. Well, we're glad you're here, and thank you for being our
Yeah.
guest tonight as
Thank
well.
you.
If you know someone that would benefit by watching this program, good news, it's going to be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.
Thank you.